Hello everyone, welcome to another episode of Next Saviours Essential Question Series for NEET PG 2025 Medicine Part 17. Today we are going to have a discussion on how to reach the diagnosis of pulmonary embolism. You see, whenever the examiner constructs a question on pulmonary embolism, then he used to keep these differential diagnoses in mind because they share the common clinical features of chest pain, anxiety, tachypnea, tachycardia, restlessness, and particularly the fat embolism syndrome. Because as a NEET PG aspirant, we are in a habit of jumping to the conclusion of fat embolism syndrome whenever we see any orthopedic procedure being mentioned in the question. And this could prove wrong. So let's start with the question without wasting any time further. That a 56-year-old man presents to the emergency department with a sudden onset of dyspnea and pleuritic chest pain that started 2 hours ago while he was resting at home. Now, the pain is described as sharp and worsens with deep inspiration, but it does not radiate. He also reports a mild episode of hemoptysis, but denies any history of trauma, vomiting, or recent long fights. Now, his past medical history is significant for hypertension, hyperlipidemia, and he was recently discharged following an elective total hip replacement 10 days ago. Now, he has been most sedentary since the surgery, and he is a non-smoker and denies any history of chronic lung disease. Now, on physical examination, the patient appears anxious and tachypnic with a raised heart rate, raised respiratory rate, near normal blood pressure. The temperature is also normal, but there is a low oxygen saturation. So, based on this language of the question, means you cannot distinguish in between the majority of the differential diagnosis, like aortic dissection. As you know, that it typically presents with the sudden tearing chest or the back pain that radiates to the interscapular region. In case of pneumothorax, it is presented with the sudden, sharp, pleuritic chest pain, which is often unilateral. It is presenting with the acute onset dyspnea, that means shortness of the breath, the cough, which could be dry and non-productive, and the anxiety and restlessness. So as you can see, there is not much of the difference that you can make out based on these differential diagnoses. Now, as far as esophageal rupture is concerned, it is presented with severe sudden onset chest pain, often described as tearing or retrosternal, which radiates to back, shoulder, or neck. Now, the pain is aggravated by swallowing, that is rhinophagia, or deep breathing. In the history of vomiting or forceful retching is commonly presented because it is a common precipitating factor, although it is not provided to you in the question. And dyspnea and dysphagia, that means shortness of breath and difficulty of swallowing, respectively, are the features of the esophageal rupture. And fat embolism syndrome is usually presenting with, again, the tachypnea, the dyspnea or hypoxemia, which are earliest and the most common signs on the basis of which you cannot distinguish, although it is presenting with the neurological symptoms late in the stages like confusion, altered mental status, drowsiness, or even coma. These symptoms can fluctuate and are often disproportionate to the hypoxia level, and it is identified by the petechial rash. But you see, the common factors in all of them remains the chest pain, the tachypnea, the tachycardia, the anxiety, and the restlessness. And if you look at the language of the question till this point, you cannot make out much of a difference as far as all these four differential diagnoses are concerned. So let's see what is the continuation of the question then in that case. Now, if you see at the lung examination, there are clear breath sounds bilaterally. That means there is no V's, there are no rails, there are no rhonchi, there is no tracheal deviation or hyperresonance on percussion. If we go on the cardiovascular examination, there are normal heart sounds. That means there are no murmurs, there are no rubs, or there are no gallops, and there is no jugular venous distension. As far as extremities are concerned, there is no sign of deep vein thrombosis. That means no unilateral leg swelling, tenderness, or erythema. And neurological examination is also intact. That means there is no confusion or petechial rash noted. So when we see this segment of the question, then we can rule out some of the options. How? Like in case of aortic dissection, as you know very clearly, that it is often associated with the pulse asymmetry, or it is presented with the murmurs of the aortic regurgitation. And there is a widened mediastinum on the chest X-ray. If an examiner construct a question on aortic dissection, then this should have been the finding presented to you. Similarly, if you look at the esophageal rupture, what are the findings which the examiner typically presents in this case are the features of the Meckler's triad, like vomiting, chest pain, and subcutaneous emphysema. And as far as X-rays are concerned, it is presenting with the pneumomediastinum, that is air around the mediastinum, as it is evident over here. Now, pleural effusions, it is usually left-sided pleural effusion, and pneumothorax or subcutaneous emphysema, which is obviously not provided to you in this particular question. Now, in case of pneumothorax, the examiner would have provided you the presence of a sudden unilateral chest pain, absent breath sounds, and hyperresonance on percussion. And there could also be a presence of the tracheal deviation if tension pneumothorax is present. And as you know, what are the chest findings? There will be a visible pleural line with absence of the lung markings beyond. Then collapsed lung at the hilum, or there could be a mediastinal shift in case of tension pneumothorax. Then coming on finally onto the fat embolism syndrome. Fat embolism typically occurs 24 to 72 hours after a long bone fracture or any orthopedic surgery, and it presents with the triad of hypoxemia, the neurological symptoms like confusion, altered mental status, and petechial rash. Whenever you see the word petechial rash in any question related to orthopedics or a petechial rash where orthopedic surgery has been performed, then you can safely mark the answer of fat embolism syndrome. So based on these clinical features as well as the investigation findings, like there will be a sinus tachycardia with a prominent S1Q3T3 pattern, then the presence of the positive finding on CT pulmonary angiography. And this thing is particularly important in case of pulmonary embolism because it is a gold standard investigation, or you can say the investigation of choice. And why? Because it provides direct visualization of the thrombi in the pulmonary arteries, and it has a high sensitivity and specificity for detecting the emboli, including the segmental or subsegmental branches. Now, this patient, there is a history of sudden onset of dyspnea, there is a history of pleuritic chest pain, hypoxemia, recent history of total hip replacement with a strong risk factor for venous thromboembolism. So, this patient presents with a classical case of submassive pulmonary embolism. Now, why submassive pulmonary embolism? Because, based on the severity, it can be divided into massive, submassive, or low risk. How? Because in case of massive, there will be a hemodynamic instability. In case of submassive, it will be normotensive. But there are the signs of right heart strain on echocardiogram as far as low risk is concerned. So these patients are hemodynamically stable with no evidence of right ventricular dysfunction, having good prognosis. And now they are asking about the management, that which of the following is the most appropriate next step in the management of this patient. And if we look at option wise, like the first option is administer intravenous tissue plasminogen activator. Now you know that thrombolysis is reserved for massive pulmonary embolism with hemodynamic instability, like hypotension or shock features are provided. Now in this patient, because he is hemodynamically stable, so thrombolysis is inappropriate due to risk of bleeding. So this obviously is not the answer for this question. Now, if we come to the option number C, that is immediate surgical embolectomy. Embolectomy is reserved for the patients with the massive pulmonary embolism who either have a contraindication to thrombolysis or failed thrombolytic therapy. So this patient doesn't meet those criteria. So this option also is incorrect. If you look at the another option, like place a inferior vena cava filter. Now you know that inferior vena cava filters are indicated in patients who have a contraindication to anticoagulants or have recurrent thromboembolic events despite adequate anticoagulation. So this option is also incorrect. In hemodynamically stable patient with a confirmed pulmonary embolism, anticoagulation is the standard of care to prevent clot propagation and recurrence. So low molecular weight heparin is preferred over unfractionated heparin for its safety and efficacy. And that is the reason why initiate therapeutic anticoagulation with low molecular weight heparin is the correct answer for this particular question. So hope you have understood how to reach the diagnosis of pulmonary embolism by ruling out the other common differential diagnosis. In order not to miss any update, please join our Telegram group. All the best for your future examinations. Thank you very much.